before we get into the episode, I've got to tell you about something that I use all the time, and that's my X shears. These aren't your run-of-the-mill trauma shears that bend after one tough shift. X shears were designed by someone who gets it. A nurse and paramedic who is just tired of disposable junk and clunky tools that never held up. Y'all, these things are beast. Heavy duty, stainless steel blades, the titanium coating, super comfortable non-slip handles, and yeah, they come in a bunch of colors, including my favorite, purple. They're easy to clean, built to last, and come with a 5-year warranty, which is basically unheard of. And this is new, the X Shear Mini. It's only 6 inches, and it fits in your pocket or a small kit. It still cuts like a champ, but it's perfect for those lighter situations where you don't need the full-size version. So, wherever you care for patients, you want a pair of shears that actually work, and X Shears is it. I promise they'll be your new favorite shears. And you can use the code RAPID10 to get 10% off your purchase. So check them out. I put a link in the show notes for you.
Trauma can be very complex because patients don't read textbooks before they come in. It's so rude that they don't know that they're only supposed to do this. They're not supposed to come in with trauma and having a stroke. They don't know that they're not supposed to come in with trauma and they're having a STEMI. Right? And so the patients, they have histories, they have comorbidities, they have other things that we have to consider. And so trauma is so often trauma plus some kind of other pathology.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
Welcome back to the Rapid Response Run podcast. Today we're diving into trauma care, but with a twist. Trauma patients rarely come to us as clean, straightforward cases. They bring with them comorbidities, medications, environmental exposures, or medical emergencies that can complicate everything we think we know about trauma. We are calling this episode Trauma Plus because it's never just trauma. And I've got the perfect guest with me today to walk us through it, my buddy and flight nurse, Gwenny. So Gwenny, welcome back to the podcast.
Thank you so much, Sarah. I'm so happy to be here.
Yes, always happy to have you on the show. Okay, so together, Gwenny and I will go through 3 cases where trauma care gets complicated. I'll present the scenarios as if Gwenny is responding to them in real life, and then she'll walk us through her thought process, assessment priorities, and interventions. And then after each case, we'll pause for some teaching pearls before moving on. So buckle up. Let's get into it. Gwenny, real quick, for those of you that maybe don't know, if you just introduce yourself, what you're doing in the world, and maybe like why you love flight nursing, then we'll do the cases.
Yes, absolutely. Well, hi guys. My name is Nurse Gwenny. I have been an ER nurse for over 10 years, and then I started flying about 7 or 8 years ago in summer of 2018. So however many years ago that is, 7, I believe. Not good at math there, obviously.
But you're good at other things.
Yes. Medication math, I can do that on the fly, but apparently counting years, I'm not. So yeah, I've been flying for the last 7 years, and currently I do Nurse Gwenny full time. So I make Instagram, TikTok videos, just little snippets here and there that are meant to spark your curiosity on various topics and to give you maybe little tidbits of information. And then you might see that video and you say, gosh, I didn't know that about the shock index. Let me go read more about shock index. That's one we're going to talk about today, right? And I have some webinars that I teach. I'm currently working on some long form content. I've just written a couple new books this summer that are meant to be clinical guides for ER nurses and for pre-hospital providers. So that's what I do. I still work in the ER, PRN, 2 or 3 shifts a month. I still work on the helicopter, 2 or 3 shifts a month. And I have 5 kids and an amazing husband. So it's quite a busy life, but I enjoy every bit of it.
I'm with you. 2 jobs and 5 kids and an amazing husband. Let's do this thing. All right. So here is your first case, Gwenny. You are working in a small ER. It's not a trauma center. And you get ready to report with the following patient. It's a 78-year-old male, restrained driver in a low-speed motor vehicle collision. He's alert and oriented ×4 with a scalp laceration, which they're describing as small. Vital signs for stable en route. Blood pressure 138/82. Heart rate's 88. Breathing 18 times a minute. SAT is 97%. Okay. So upon arrival, you begin your assessment. You're gathering information. You learn from the patient that he takes, quote, 2 heart pills and a blood thinner for atrial fibrillation. So you throw the patient on the monitor. You step out to grab some IV supplies and a blanket. And when you return, you notice he's becoming mildly confused when he seemed very oriented just a little bit ago. He's also irritable. His heart rate has crept up to like 102, 105, 110. Blood pressure is still looking fine, 135 systolic. Oxygen saturation is unchanged, and there's no obvious external bleeding. So, questions for you at this point. What is on your differential for his change in mental status?
Yeah, so I don't trust elderly patients who have a traumatic mechanism any further than I can sling a piano, right? I'm going to assume that they are bleeding from the somewhere, whether it's where I can see it, that external scalp laceration. You just said bleeding was controlled on that. Fantastic. All those scalp lacerations, they hold the potential to bleed like a stuck pig. Oh my gosh, those can bleed like crazy, especially if this patient is on a blood thinner. But I'm worried about bleeding where I can't see it, and that would be inside his noggin. If he has a scalp laceration, that tells me he either bonked his head or something bonked him, and I'm worried about bleeding on the inside of the head. Now, anytime I have a trauma patient, Sarah, the first thing I want to look at is their shock index, right? And shock index is their heart rate divided by their systolic blood pressure. Now, I know that it's going to be wonky in this patient. If he's on 2 heart pills, I'm guessing one of them is probably going to be a beta blocker. That's like standard issue. Once you hit the age of 70, you're on metformin, metoprolol, and the standard issue American elderly medications. And so those beta blockers are going to prevent that patient from having a shock index that's really obvious to me, right? If I have a younger adult who's not on any medications and they're in a traumatic mechanism and they've lost a lot of blood, I expect they're going to have a high heart rate and either a soft or a low blood pressure. As we know, hypotension is the very last thing, the very last indicator that our patient is in hypovolemic shock, right? So that's why we look at this shock index, their heart rate compared to their systolic. But I know if this patient's on a beta blocker, that systolic blood pressure of 138 that you just mentioned, or 135, that's probably low for him, right? Mm-hmm. What is a typical blood pressure in our patients that are, how old is this guy? Did you say 76?
78.
78, yeah. We get high blood pressure when we're old. Our bodies just do it. Our vasculature gets stiff and crunchy. Our patients have high blood pressure. And so 138 is probably low for him, right? And he can't engage in that compensatory mechanism of tachycardia because of that beta blocker or whatever medication he's on for a rate controller. So I know that I'm going to have to look very closely at this patient. I'm going to have to mind him really well because he's not going to be throwing the red flags at me that I'm used to seeing in my other patients. And so for me, I would prioritize getting that IV, grabbing some labs, because I definitely want to get coags on this patient. I want to make sure that he's in a therapeutic range and his INR isn't higher than his hemoglobin, Klutschstein pearls, and get this gentleman to head CT. Of course, the physician is going to come in and order all of this stuff. I'm not just out here Wild Westing it by myself. But get this patient to head CT because I'm sure you're thinking the same thing. He probably has a bleed in there.
Yeah. So like you had mentioned, we like shock index. It's a great indicator. But if he's probably on some sort of OLOL, that might not be the best. Are there any other like subtle signs of decompensation that you might have noticed in this patient or in any elderly patient that can help lead us towards the like red flag zone?
Oh yeah, that altered mental status. I always assume that somebody acting a little loopy is an organic cause until proven otherwise. Might they just be a weirdo at baseline? Possibly, right? It's one to know one. But I always am suspicious. Are they hypoxic? Do they have some kind of neuro insult? I'm always looking for, as a matter of fact, I just worked in the ER the other day, and I had a patient that was kind of a little bit of a weirdo. And after the nurse practitioner saw him and came out, I said, okay, is there something going on in his head? Do we need to scan his head? He said, nah, I think he's just a goofball. I said, okay, right. That change in mental status is a huge one. In addition, I love skin as a vital sign. Are they cool? Are they warm? Are they diaphoretic? Are they dry? Or do they have tenting? You and I have talked about before. Are they thirsty? Right? I did a video on this a couple of months ago. You were talking about how, well, I won't steal your thunder, how nobody had to teach you when a patient says, I'm thirsty, right? That's concerning.
No one told me in nursing school that like thirsty is something I'd be concerned about, but like patient after patient after patient that's like hemorrhaging out from somewhere has looked at me and said, I'm so thirsty. I'm like, who's asking for water in a time like this, you know? And it just, after multiple exposures to this question coming from patients who were declining and losing mass amounts of volume, I kind of made the connection. Oh, thirsty is actually a compensatory response. The body's trying to respond to their loss of volume and telling them drink more water. And so when I hear that, I'm so thirsty, nurse, my head goes to, okay, what are we missing? Where are they bleeding from? How much have they lost that I just haven't noticed or picked up on yet? So the thirsty response is definitely a red flag for me as well.
Yeah, part of that renin-angiotensin-aldosterone system, part of that response is to create thirst so the patient will take on more liquid.
So you had already mentioned you are prioritizing getting the patient to CT. Are there any other like safety things that you are preparing for, getting equipment out, letting people know, like what else is going through Gwenny's mind so we can just tap into that years of experience and hindsight wisdom?
Right. If he's not already in a room where I've got supplies available to manage that airway, we want to get him in a trauma bay, or when he comes back from CT, let's take him to the trauma bay. Because if he is starting to get altered and he just got here, what's he going to be like in 20 minutes? What's he going to be like in 60 minutes, right? Because if this is a small rural facility, it's not a trauma center. He's going to have to get to a trauma center if he does have the neuro insult that we are concerned about with a hemorrhagic injury, an intracranial bleed. It's going to take the flight crew time to get there, right? And then it's going to take him to fly to wherever he's going. And so it's not just about managing the patient's airway. It's if there's a patency problem right now, we're talking about looking at his course of his care, right? I need him to be able to get to that trauma center. And so while he might be able to maintain it right now, I can look at him and I can trend and say, okay, I don't trust him to maintain this airway or maintain this respiratory drive, right? Because if we're talking about some kind of intracranial hemorrhage, we're also going to be looking for Cushing's triad, where we get that systolic hypertension, we're going to get bradycardia, and the last thing that we will get is an altered breathing pattern, right? And that's when we're worried for that increasing intracranial pressure. So I know that that's going to impact his ability to maintain his respiratory rate. So I can look forward, I can predict, right, how well he's going to do. And of course, when I say I'm talking about the whole healthcare team, right? The physician is going to be there with us, managing that airway to be able to get that patient to his definitive care.
Yeah, for sure. One other little thing I wanted to bring up, and this is something I face a lot as a rapid nurse, is we need the CAT scan. I need to know diagnostically what we're dealing with here. But then the question is like, is the patient safe to get there? And do I need to establish an airway prior to this little road trip, right? And with neuro patients, it's even more complicated because I want to have the ability to perform a neuro assessment. But if we RSI him and put a tube in, it's much more difficult to determine if the patient is having altered mental status or neuro changes, right? So it's always this quandary of like, I'm worried about this patient declining and needing an airway. And I really don't want to intubate CAT scan. I will, but I really don't want to. But I also don't want to intubate here right now because then I lose my neuro assessment. So it is an interdisciplinary collaborative discussion as to what's going to be best for this patient.
Yes.
So based on what I presented right now, I personally would feel okay traveling without an airway, but you better know I got the ambu bag attached to the bed and I'm probably bringing a provider or someone who can intubate this patient and I'm watching like a hawk. This is not someone that I was going to send to CT with the CT tech or like a transporter. I am going with this patient. I've seen a neuro decline in the last 5 minutes, I'm anticipating more neurodecline, and I'm not leaving this patient's side until we can see what we're dealing with.
Absolutely. I think sticking with your patient is an underappreciated clinical tool, right? It's so often we go into the room, we do the things that we need to do, and then we come back out to the nurse's station. I love having a portable documentation, I know we're not supposed to say cow anymore, your computer on wheels, right? But that's what I grew up calling it.
We call them wows at my hospital.
Oh, yes. Workstation on wheels.
Workstation on wheels. Mm-hmm.
Yeah. So taking it to the bedside and just not leaving them, right? And so staying with them or going with them to CT. Is it a pain in the neck because you've got 14,000 other things to do? Yeah, a little bit. But if it enters my head to go, I don't know if I trust that patient to go to CT by themselves, I know to listen to that still small voice inside me that prompts me, because I know that she's trying to save me from grief, right? She's trying to save me from trouble down the road. And if I was wrong and the patient does great, then fine. What did that cost me? 8 minutes of my time, right? And I got to help the CT tech. They appreciate the extra set of hands. They're constantly moving patients over by themselves, and chit chat with them while their patients get their CT, and all is well that ends well, as long as they didn't need me. But if they did need me, I'm so glad that I did listen to that prompting to go with the patient. And I've never regretted going with a patient. I have regretted sending a patient to CT without staying on the monitor and me staying with them.
For sure.
Now, the last thing I want to bring up about this case is you brought up a good point about if we RSI them and we give them sedatives and paralytics, it limits our ability to perform that neuro assessment on that patient. And that's something that we have to consider pre-hospital. Most us flight clinicians, we love ketamine and rock. That is our RSI recipe for success. We absolutely love it, right? But what happens with rocuronium is our patients are going to be paralyzed for 45 or maybe even 60 minutes, particularly if they have liver or renal impairment. Those paralytics stay on board a little bit longer. And I can't tell you the number of times that I've intubated a patient pre-hospital and I get to the hospital and they're like, why did you use rock instead of sucks? And I'm like, because sucks has like 43,000 contraindications. Okay, just because I like rock and the math is easier to do with rocuronium, okay? But we do have to consider that if this is a patient that's got some kind of TBI or they're having a stroke or something that we need to get a neuro assessment on this patient, I have to consider perhaps sucks might be a better option here instead of the rocuronium.
Yeah, good points. Okay, so as Nurse Gwenny's little voice in the back of her head said, there is, in fact, an intracranial bleed going on with this patient, and he does, in fact, decline in CAT scan, but you were ready for it because you had the team with you that was going to intubate, you had your BVM ready to go, you responded to this patient's changes, and you saved a life. Okay, the end. Let's review. So as far as this particular case, I just wanted to point out that even, quote, minor trauma can actually be life-threatening in elderly patients, especially elderly patients with anticoagulation. And then the vital signs situation, they can look deceptively normal because they're blunted due to some compensatory mechanisms or medications on board. So mental status change, like this guy, can often be the first sign of decompensation. All right. Well done, Gwenny. Well done. Case number 2. You are dispatched to a 34-year-old male involved in an ATV rollover. He was pinned under the ATV in the woods by himself for several hours in the winter before he was discovered. When you arrive, he's pale, he's shivering, but he does have a GCS of 14. Initial vitals are a heart rate of 110, blood pressure is 112/70, respiratory rate's 22, SAT's 95. His left thigh looks deformed, likely a femur fracture. Okay, so what's your immediate concerns on this patient, especially considering the whole hypothermia plus trauma combo?
Yeah, absolutely. Well, we would be remiss to do a trauma podcast and not mention the trauma triad of death, right? And the 3 elements of the trauma triad of death are acidosis, which happens because this patient is malperfused, right? And then we switch into anaerobic cellular metabolism, and the waste product there is going to be lactic acid. So the metabolic acidosis in our trauma patients is due to malperfusion, usually due to blood loss. We also have coagulopathy. Because we're losing so much of our blood, we're also losing those clotting factors, and we lose our ability to form those clots, as well as hypothermia. That's the 3rd part of the trauma triad. And in hypothermia, all 3 of these things worsen each other, right? So we don't clot as well when we are in an acidotic state. We really don't form clots well when we are cold. Those enzymes that work to form blood clots in our bleeding patients are temperature dependent. They don't work well at cold temperatures. Even just a couple of degrees is enough to impair a patient's ability to clot. And so if your patient is hypothermic, that's going to worsen the coagulopathy, which is going to increase blood loss, which is going to increase acidosis. And these patients get caught into a spiral where they are just spiraling toward death. So my first order of business for this patient, get the four-wheeler off of him and get him into the back of the ambulance, right? When we fly into a scene, there's usually an ambulance on scene, and we work on the patient in the ambulance and then load them up in the helicopter and get them to the hospital. I would want to crank up the heat in that ambulance. And oftentimes, in anticipation of getting to a patient, a trauma patient, we'll crank up the temperature in the helicopter and get it hot as heck back there. And my personal motto for when I'm caring for trauma patients, if I'm not sweating, it's not warm enough, right? Because not only is this patient going to be cold from their prolonged cold exposure, but they're also going to be cold because we had to get them out of the woods, and we probably did that on a long spine board. And so we have conductive heat loss, that being laying on a cold long spine board. Like, think about even when you just go outside to sit on your lawn furniture and it's chilly outside and you sit on it, you're like, oh, it's cold on my butt, right? This is cold on this guy's whole body, and we just got him trauma naked. And so here he is, naked as the day he was born, laying on a cold spine board. We're dragging him through the woods. We've got to warm this patient up. Now, bleeding. You said he had a deformed femur. Our femur is the longest bone in our body, and it can bleed 1 liter to 1.5 liters. Even if it's a closed fracture, it's still bleeding inside of there, right? Sarah, one time I was taking care of a professional motocross motorcycle guy that presented to the emergency department. His throttle got stuck, and he slammed into the wall going like 55 miles an hour at the stadium thing that they were having their motocross event at. I obviously know nothing about motocross or what the words are that I'm supposed to be using. So anyway,
I'm tracking.
Yeah, he's got this really expensive looking outfit on, and part of it is almost like compression, like a neoprene kind of fabric on his legs. And of course, we go to get him trauma naked, and I'm cutting it off, and I'm like, sorry, bro, this looks real expensive. I hope your sponsors can get you a new outfit as I'm cutting this off of him. And he had a floating knee, which is a broken femur and a broken tib fib, right? Surgical emergency. He has to go to OR, lickety split, to get that fixed. But I distinctly remember when I cut off those really thick, neoprene pants, it was like his thigh was like a hot air balloon. It just went, and it filled up. And I was like, we are in trouble. It filled up with blood so quickly because those pants had been tamponading that bleed from his broken femur. It was a closed femur. It didn't even puncture the skin. It was bleeding inside of there. And so I looked at ortho. I said, you want to go to the OR? And he was like, we sure do. So we stopped by the CT on our way, and he went up to OR and he got that repaired. But I will never forget watching it go whomp and fill up with blood right before my eyes. Like, time slowed down, and it became a core memory for me, right? In the potential for blood loss in a femur fracture.
For sure. Okay. So you talked about making sure that your environment is warm. What else are you doing with regards to managing hypothermia, maybe outside of the hospital? And then what do you do when you get to the hospital?
Yeah, so we keep warmed fluids on the helicopter. We keep 1 liter of LR and 1 liter of NS. So anytime I have to give a patient fluids, even if they're not a trauma patient, if it's chilly outside or if the patient is cold, little old ladies, they're just always cold. If I have to give them fluids, I reach for those warmed fluids. We got to throw them out every 2 weeks anyway. So I'm like, let's use them before they expire. So I like to give those warmed fluids. In addition, if this is a trauma patient and we're going to be giving them blood, we do not give cold blood, right? We carry it in a cooler. We keep it cold. Everybody knows when you get blood from the blood bank, it's cold. We always warm it up. We have a pretty cool little machine that warms it up for us in the tubing that we obviously wouldn't have room for a Belmont in the helicopter. But we have a portable version of something that warms it up and giving this patient warm blood. I'm not going to give this patient fluids because we know that worsens that coagulopathy in that trauma triad of death, right? I overheard a story one time of an ER doctor that was talking to the trauma surgeon as they were waiting for EMS to bring in a patient. They said, do we know if this patient is on a blood thinner? And the ER said, yes. Unfortunately, they are on normal saline, right? And that's the blood thinner that the patient is on. And so it used to, when you and I were in nursing school and new nurses, we were taught, bilateral 16s and 2 liters of fluid on a pressure bag, right?
Poured, yeah.
And so all we were doing was we were filling the tank, but we were filling the tank with something that was going to then drain the tank even faster because we were turning their blood into pink Kool-Aid. And so we have to be very careful with the fluids that we're giving. And I'm so thrilled to see so many pre-hospital services starting to carry blood. Like, it's the cool thing to do, to integrate blood into your ground services now. And it's available in so many places. It used to be pretty exclusive and only, a few air programs carried blood. Now it's standard that pretty much every air medical program carries blood products. A lot of people are carrying whole blood, which we know is better than component therapy. And a lot of ground services now are giving blood products too. So very cool and a great thing to see progressing in the pre-hospital environment.
Love it. Okay, so we would be remiss to talk about just the trauma triad of death and not to mention the diamond. I'm curious, as far as hypocalcemia, do you guys have a protocol pre-hospital for at what point you add in the calcium administration? In the ER you work in, at what point do you add calcium to prevent that diamond from also worsening the patient's cascade spiral towards death?
I'm glad you brought it up. So the lethal diamond is the trauma triad plus hypocalcemia. And calcium, as we know, is required for clotting. We cannot clot without using calcium. And what happens in our patients, I was actually just reading about it 2 nights ago because I was working on some long form content on a trauma scenario and looking at the lethal diamond. And due to the pathology in these patients of the bleeding, that is using up what calcium we have. And then the red blood cells that we give the patients, I talked about a lot of us are carrying component therapy and not yet whole blood. That's what my service still carries. We carry 1 unit of plasma and 2 units of packed red blood cells. We preserve packed red blood cells with calcium citrate. And that citrate binds up all of our free calcium because we don't want that blood in the bag, in the blood bank. We don't want that to form one big clot and then us give the patient a mega clot, right? We want to give them blood, not a clot. And as we know, once blood is leaving the body, it usually forms a clot. I'm sure you've seen on the trauma bay floor or a rapid response where a patient has been bleeding. If they bleed a puddle on the floor, it turns into a little blood pancake, right? It will clot right there, even outside the patient's body. And we don't want that to happen in the bag. And so we preserve it with citrate. And when we give that blood to the patient, now that citrate is in their body, and citrate is like Pac-Man, and it's looking for all the calcium. It's chomping all of it up. Now, in a healthy patient, their liver will metabolize citrate within 5 minutes. But we know that the number one cause of trauma in the United States is hold my beer. So many of our trauma patients don't have a healthy functioning liver that can metabolize and process that citrate. In addition, even if they do have a sparkling clean liver, they're not perfusing appropriately. They've lost a lot of their blood. And so they're not cycling that blood through the liver at a normal rate. And so their liver is not metabolizing that citrate. And so our protocols is every 2 units of packed red blood cells, we give calcium. And then when I talk about this, people usually ask, okay, well, should I give calcium gluconate or calcium chloride? Let's talk about the difference between those two. So you get more bang for your buck with calcium chloride. It's got about 4 times the elemental calcium as calcium gluconate. However, it can be very vasocaustic, right? And I'll tell you what decides how I decide if I'm going to give calcium gluconate or calcium chloride is whichever one isn't on back order and it's in my bag. And so to give calcium chloride, it's recommended that you only give it through a large bore IV or even a central line. But if you've got a 20 in the forearm because that's all you could get, then that's what you got to give. And so usually I'll put it in a 100 ml bag and just let it flow into gravity. Whereas gluconate, I know I can give that and not cause harm to the vasculature on that patient. So, but sometimes we'll give 2 units of calcium gluconate or 1 little vial of calcium chloride.
Okay, got it. So we are warming this patient with environmental warmth, maybe with some blankets, warmed fluids, warm blood, preferably. We are thinking about their calcium level and mitigating that risk because we know it's going to worsen the coagulopathy if we don't have enough calcium on board. We know we're going to worsen their hypocalcemia as we continue to give blood products. So we're just getting ahead of that problem before it even exists. Okay. Excellent. Anything else you want to add as far as hypothermia, maybe masking some of the initial presentation that would be concerning to a patient who is bleeding? Quick pause. I've got a question for you. Have you ever walked away from a resuscitation thinking, that went pretty well, but how can we be even better next time? Well, I hope you've asked that because that's how we keep getting better and better as clinicians and as teams. Let me tell you about another great podcast that you need to check out. In the Heart of Care is produced by RQI Partners and hosted by Dr. Ash Panchal. You may remember him from episode 140. He's an emergency physician and educator who really understands what it takes to lead when the pressure's on. This show takes you inside the real work of building readiness, what systems and strategies actually hold up during critical events, and how teams train, communicate, and grow from both wins and missteps. You'll hear honest stories from the front lines, lessons from sim labs, and practical tools that can help your team perform better when it matters the most. So whether you're at the bedside, running education, or leading a team, there's something in every episode for you. In the Heart of Care is available now, wherever you get your podcast. Give it a listen. Now, back to the episode.
Well, that patient's going to have altered mental status too, right? We know that that's going to impair his neurologic function. If he's below 30 degrees Celsius, he can no longer shiver, right? I know that that's also going to slow down his metabolic rate. And so with my medications, he either is going to require a smaller dose, or if I give him a regular size dose, it's going to last longer because he's not metabolizing it nearly as quickly, right? You ever taken care of a patient on methamphetamine and you don't have enough benzos or narcotics to treat their pain or sedate them because their metabolic rate is so high? They just chew everything so quickly. They're just burning through what you're giving them. These cold patients are the opposite, right? You give them a dose of fentanyl and they're still good to go like 40 minutes later because they're just not metabolizing it like we normally see patients metabolizing those meds.
Very good points. All right. In summary, hypothermia can mask shock a little bit, and it definitely contributes to the lethal diamond, coagulopathy, acidosis, hypocalcemia, and of course, hypothermia. Early recognition and aggressive warming measures are critical alongside trauma resuscitation. Okay, case number 3. You ready, Gwenny?
I'm ready for it.
All right. You respond to a 55-year-old female who fell from a ladder. What's she doing on the ladder, you may ask? Question for another day. She's now complaining of chest pain and hip pain and back pain and shortness of breath. Her initial vitals are a heart rate of 130, blood pressure 88/60. She's breathing 24 times a minute. Stat is 92%. Her skin is cool and clammy. On exam, you don't find any significant external injuries. There is some bruising on her ribs, and she's very tender around her pelvis. Okay. Any further assessments or data you want to gather after hearing this synopsis?
So if she's complaining of chest pain, we cannot definitively rule it out as exclusively caused by the trauma until we get a 12 lead, right?
Thank you.
And every time I'm bamboozled by a trauma and medical patient, I tell myself, I'm never falling for this again. But inevitably, I do, right? I get a trauma patient and I'm anchor biased, right? I'm telling myself this is a trauma patient. Actually, my medical director did us a good bamboozle earlier this year with a similar patient, one that we were dispatched to a trauma, right? This was a made up scenario that we had go to quarterly simulations to test out, right? So I'm going to take a little side quest from your case and talk about this imaginary case we did.
Okay.
So we got dispatched to a patient on methamphetamine who had jumped off of a roof and now is having chest pain and is dyspneic and short of breath. And so when we're pretending to fly there, I'm thinking to myself, like, he jumped off a roof. He probably has a pneumothorax and that's why he can't breathe. And so we get there and I'm listening and I do hear lung sounds on both sides. And the patient mannequin is really dyspneic and keeps coughing. And I'm like, this doesn't fit the picture of a pneumothorax. And so we go to intubate the patient. And when I'm preparing to intubate, the people who are running the mannequin are saying there's so much pink frothy sputum coming out of the airway. And I'm like, okay, I'll suction. And they're like, no, there's even more. And I'm thinking, like, what? I'm picking up that they're trying to lead me astray. And I'm like, waiting for their shoe to drop. Like, what is the trick they're trying to play on me here? And I look at the monitor we've got the patient on. His pressure's like 240/120. And I'm like, none of this is adding up. Usually in a pneumothorax, you're going to have a low blood pressure, right? And so I'm thinking, what on earth is going on? And eventually I make the decision like, okay, this is SCAPE. I can't ignore this any longer, right? This is a sympathetic crashing acute pulmonary edema patient. He's hypertensive. Wildly hypertensive. He's got this pulmonary edema. He's dyspneic. And I put him on CPAP instead of intubating him in the scenario. And he does really well. And then I'm like, at the end of the scenario, I'm like, what just happened here? And the whole point of the scenario wasn't to get us to recognize the SCAPE. It was to get us to abandon that anchor bias. And that's really difficult to do, Sarah. I'm sure you know that. I'm sure you see this as a rapid response nurse. where you're fresh on scene. You have new eyes. You don't have old information, where you might see that the primary nurse for the patient is anchored to it being XYZ, right? And because once we lock onto an idea, it's really hard for us to do an about face and to take in new information. It's easy for you to walk in and go, no, this isn't XYZ. This is ABC. And then I'm sure the primary nurse is like, oh my gosh, I hadn't even considered it because I was really anchored to it being this. And so that's what I did in that scenario is I was so anchored to the idea that this was going to be a tension pneumothorax. And turns out it was actually scape.
So I think similar to your case where you were called out to a trauma activation. So you're thinking, okay, where is the trauma? What's the injury? You're like going down that route. That's your anchor. Same with rapid response. This patient's already been admitted to the hospital. Their admission diagnosis is sepsis. So now they have hypotension tachycardia. We're thinking, okay, now it's septic shock. But what if it's not? What if they have a dissecting aortic aneurysm? I've had that before. What if it's not the post-surgical complication? What if it's something totally unrelated? I've seen it so many times where even I'm like, okay, so what's the history? And once I hear the history, I'm like, oh, maybe it's this thing. And I'm like, totally, totally wrong. So yes, you're right. We have to kind of keep our minds open. How many car accident patients have I cared for? And we're looking for the trauma injury. Come to find out they had a stroke behind the wheel, which caused the car accident in the first place. So the little deformed femur is, yes, it's a problem, but we also need to address the brain cells that are actively dying from their stroke. So yes, anchoring bias is a real thing, even for experienced professionals. So let's dive into this case a little further. So you had mentioned the patient said they had chest pain. And so you want to get a 12-lead EKG, right?
I want to get a 12-lead. And actually, I would have also been looking for electrical alternans because I would be thinking blunt force trauma to the chest, there's a good chance I have developed a cardiac tamponade. And so I'm going to want to perform a 12-lead to see if I can see that electrical alternans. That's where we get a tall QRS complex, a tiny QRS complex, right? We get alternans. It's alternating tall amplitude, short amplitude. And the reason we see that in cardiac tamponade is because that sac, that pericardium that holds the heart, if patients would have blunt force trauma, that can fill up with blood. We actually see it more often in medical patients than in trauma patients, but we're talking about trauma today. So say the pericardial sac fills up with blood due to blunt force trauma, the heart essentially goes ding dong, ding dong. It's swinging back and forth inside that sac is normally snug against the heart, holding it. But if it's full of blood, the heart is ding donging back and forth. And when it dings forward, it's closer to those 12-lead, those electrodes. And so it's picking up a taller amplitude. Whereas on the back swing of the heart, it's further away from the electrodes. And so we get a shorter amplitude. So that's what I would have been looking for on the 12-lead. But in this patient, when I performed the 12-lead,
instead, you found elevation, ST elevation specifically, and V2, 3, V4, and the blood pressure is continuing to drop though, Gwenny. So my question for you is now you have a diagnosed STEMI and a hypotensive patient with pelvic pain. So you got lots going on. You got a lot to deal with here. What interventions are you prioritizing now that you have a trauma and a medical emergency overlapping?
Yeah, this is going to be really complicated because I don't want to give pressors in a trauma patient because that doesn't help them, right? But if this is hypovolemic shock because she's broken her pelvis and she's bleeding into her pelvis, number one, I need to bind to the pelvis and then give her blood products. But if she's hypotensive because she's in cardiogenic shock, I'm going to want to give her a pressor and support her inotropy, right? And so it's going to be difficult to, okay, what came first, the chicken or the egg here? I am very concerned. We need to get that patient to definitive care. And even in the ER, they might be like, do we go to cath lab? Do we go to trauma, right? We're going to have to scan that patient before we take him to cath lab to take care of their heart attack, right? Their myocardial infarction, because if she is bleeding into her pelvis, we need to address that, right? It was just in the last week that I took care of a patient, an elderly. It was kind of like a mix of all three of these things happened together. She forgot to put her car in park. And when she got out of it, it started rolling backwards, knocked her down. She was 80 years old. And so we had the geriatric considerations. She had polypharmacy, right? She was on all kinds of medications. So that affected her presentation. She also had some confusion going on. It was like this. It was a whole bunch of these things. And we were like, does she have medical problems going on? The car door knocked her over. It wasn't like the car ran over her. And she had bleeding in her pelvis, an active bleed. And so there was a lot going on with this patient. I was like, I don't even know where to begin right, with these patients. So it can be very complex and nuanced to take care of these medical patients. And just like you said, you've had a neuro patient that was in a car accident that actually happened many, many years ago when I used to work at a trauma center. It was the lady that answered the phone at the hospital. And there was kind of a minor car accident. It wasn't that bad. But when firefighters get there, they go to extricate her out of the vehicle. And she's saying the name of the hospital as if she's answering the phone. And she just keeps saying it over and over. How can I transfer your call? Or who are you? She was her spiel that she says 1,000 times a day answering the phone. And so the firefighters were like, well, we'll take her to that hospital. Is she asking us to take her there? Of course, we recognize her voice. We had never seen her face, but we all recognize her voice when she comes into the trauma bay and she's talking. And we're thinking like her traumatic mechanism isn't that bad. What's going on here? She was having a stroke and she was stuck in this cycle of giving her spiel of answering the phone, right? And so these patients that are dual medical and trauma can be exceptionally difficult to manage and really require a lot of brain power on our part.
For sure. For sure. Is there anything that you do that helps prevent anchoring bias? Are there any steps you go through or questions you ask yourself to keep yourself from just anchoring onto something and going down that train and forgetting all the other potential diagnoses?
Yeah, there's a few things that I do because I have fallen for it so many times, right? Because I've been bamboozled enough times that I'm like, I'm not falling for this again. On my way to a flight, so we get the benefit, right? And in the helicopter environment is we always have a response phase. We always have to get to wherever the patient is. Now, sometimes it's only 3 or 4 minutes. Sometimes it's maybe 20 minutes to fly to where the patient is. But my partner rides up front with the pilot and I'm in the back. I'm usually getting a few things ready, right? If we're on our way to a trauma patient, I'll get the blood tubing out, the blood warmer. I'll spike a liter of fluids. I don't spike the blood until we absolutely commit to giving the blood. But I'll get a lot of things ready. I'll turn the vent on. I'll set it up to, if we're going to a male, I'll set it up for a 6-foot tall male. If we're going for a woman, I'll set it up for a 5'5" female, put it in standby. That way, if we have to intubate them and things, we can just hit go. It's good to go. Kind of middle of the range values that will work for most patients. And so while I'm doing all of that, I'm also talking through the radio to my partner, our ICS system, where I'll say, okay, here's the information that we have. And sometimes it's this much information. And sometimes it's wildly inaccurate, right? Not because dispatch doesn't know what they're doing. They absolutely know what they're doing. They're experts at that. But they are relying on information from bystanders. And as we know, bystanders are reliably unreliable. And that's okay. They're not expected to be experts on assessing a scene. That's not their area of expertise. And so they're giving what information they can see. Dispatch is relaying it to us. And we're trying to operate off of that. And so probably the biggest one a case where we got called out for a possible kidney stone. And I thought, this is really weird. We typically don't fly out to go get a kidney stone patient, but it was way out in the boonies, really far from the hospital. And I was like, well, maybe it's a BLS crew who can't give pain meds or start an IV. And so they're calling us for that. This is weird. We land, we jump in the back of the hospital and a baby slips out of the vagina of this patient. I was like, that's not a kidney. That's the biggest kidney stone I've ever seen. And I've never seen one come out the vagina, but okay. Right. And so we have to be able to take in new information and pivot. But what I try to do on the way to the patient is, okay, we've been told it's XYZ. What if it's not that? What if when we get there? And my partner and I talk about it. And I'm really fortunate to be part of a really incredible flight team with super smart paramedics. And I love bouncing ideas off of them and us working together to say, okay, we're called for this, but what if we see this? Okay, what if we see this?
What if it's not a kidney stone and it's actually a baby? What if?
And a preterm baby that's going to require us to resuscitate. And mom is going to bleed everywhere, right?
That wasn't on your differential for your renal stone patient in the woods.
That was the case. I did cry in the supply room after that one. Yeah.
As we do. Yeah, that's understandable.
So anchoring bias is a real thing and we have to actively work against it, right? I appreciate you asking me, what do I do? Because it's an active process to fight against an anchor bias. It doesn't just happen on its own. Because as we've talked about in all of these case studies, sometimes the signs are very subtle. And if we're not actively looking for those signs, if we're not having an open mind to consider other differentials, we're going to miss it. And so we have to have an open mind to other diagnoses. We've got to have noticing eyes. We talk about that with our kids all the time, right? Have noticing eyes. Notice that the toilet paper roll is empty and change it. Have noticing eyes about your patients and say, you know what? Is he goofy or is he having altered mental status? He wasn't goofy 5 minutes ago. I'm worried. Maybe let's reassess. So just always being on the lookout and being vigilant to notice any subtle changes in our patients.
Yeah, good. And continuing to do that. Once you come across your diagnosis, be like, hold on, but could there be more? Could there be more things? I've had patients who we were sure they were just fluid overloaded because I can hear the fluid in their lungs. We're like, oh yeah, they're fluid overloaded. They're desaturated. We're going to intubate them. But they're actually fluid overloaded and they have a PE. Like they can have as many diagnoses as they damn well please, right? What is it? Hickham's dictum or something like that. Patients can have as many diagnoses as they want. So we just have to keep looking, making sure that we are treating the right thing and that possibly there could be another right thing that also needs to be addressed in our patients.
Yeah, absolutely.
So Gwenny, with regards to trauma plus something else, are there any other pearls or potential pitfalls or takeaways that you want the listeners to know with regards to this patient population?
Yeah. So I've seen in the past that there's usually two camps of providers, people who love trauma, right? They wear a badge that says trauma drama queen or, trauma llama or something like that. People who love the trauma. And trauma can be fun because it's like, oh, sexy or really funny story or really, whoa, dramatic story of
blood, guts, bones.
Yeah, kind of crazy. And then there's the camp of people who are like, I prefer medical patients because I actually have to use my brain on medical patients. It's like a puzzle that I have to put together. Yeah. Right? I've said that 1,000 times. And we talk about how trauma's easy, right? Blood round and round, air in and out, we're good to go. But as we've just talked about in these 3 case studies, trauma can be so complex and nuanced, and it's rarely just a straightforward, easy trauma case where it's control the bleeding, get them to the definitive care that they need, right? Whether that's surgical repair or, what have you. But trauma can be very complex because patients don't read textbooks before they come in. It's so rude that they don't know that they're only supposed to do this. They're not supposed to come in with trauma and having a stroke. They don't know that they're not supposed to come in with trauma and they're having a STEMI, right? And so the patients they have history, they have comorbidities, they have other things that we have to consider. And so trauma is so often trauma plus some kind of other pathology.
Gwenny, I think you hit the nail on the head. I, too, have been the cocky nurse that said, I prefer medical patients. I like to use my brain. Trauma is way too easy. And then I've been humbled time and time again when it comes to trauma care because trauma is rarely straightforward. Today, we saw 3 examples of how confounding factors can mask or worsen trauma. The elderly patient on anticoagulation, the hypothermic patient, which can complicate bleeding, the cardiac event masquerading as just hypovolemic shock. The big takeaway is trauma plus something else changes everything. And it requires slowing down, widening your differential, and never relying on vital signs alone. Recognizing those subtle changes like altered mental status, unexplained trends in vital signs, thinking about the other risk factors in their history. All of that can make a huge difference between life and death for your patient. So Gwenny, thank you so much for dissecting these cases with me today. Okay, before I let you go, I know everyone that heard the podcast is like, I love this Nurse Gwenny. Where can I get more stuff from her? So can you please tell them about your books and where they can find you on social media?
Yes, absolutely. So I'm on TikTok, Instagram, Facebook, and YouTube under Nurse Gwenny, and it's Gwenny. It is, if I'm going to start keeping a jar and just put a nickel in it every time someone calls me Gwenny instead of Gwenny, but Nurse Gwenny, like Jenny, but with a gwa. But I've got a website too, nursegwenny.com. And I'm so thrilled that this summer I have published 2 new books. So I have the ER Nurses Clinical Field Guide. Guys, this is not for studying. It is for using when you've got the patient right in front of you. So it's got tabs on it so you can go, okay, we have a patient that's coming in cardiac arrest. Let me flip to the cardiac page. And I've got all things that I need for cardiac arrest. Look at how to interpret the 12 lead, your priorities for your aortic dissections. Haven't done an A-line in a while? No worries. I've got A-line waveforms and how to recognize underdampening, overdampening, all kinds of things. And then this one, I've been driving my publisher nuts, calling him every day. Are they ready yet? Are they ready yet? Are they ready yet? They're going to be ready next week. So we're taking pre-orders. But this is the pre-hospital version. It's a little bit bigger. It's got a little bit more information. But this will be good for EMTs, paramedics, and critical care paramedics and nurses. So flight, we've got aviation stuff in here. We've got cardiac devices like your Impella and your balloon pump. I've got ventilator references, all kinds of things that will help you when you've got the patient in front of you. And then it's wettable. That's my kid's word for waterproof is wettable. So if you get it messy, you can purple wipe it off there. If you get blood, guts, barf, phlegm, sputum, any kind of things on there. But I wrote this for me. When I was a new flight nurse, I took my protocols and the cases that scared me the most, or the protocols that I was least familiar with, and I made myself like this clinical reference. This is actually version 2.0 because version 1.0 went through the washer in my flight suit once and I had to redo them. But I made it in different colors and different markers so that it could grab my attention and I could find it in the heat of the moment when I had a patient who needed a crike. So I've got my steps to performing a crike. But I used these for years to help me take care of critically ill patients in the helicopter. And even sometimes I would use it in the ER, like, oh man, I haven't seen this patient forever. What do I need to remember? Turn it open. And I thought, I know that I'm not the only one that would want a resource like this. So that's why I wrote these, right? For ER nurses and for pre-hospital providers to be able to help you take care of the patient. So those are available on my website at nursegwenny.com. And I hope that people find them as useful. Like I'm using these myself and I'm really, really enjoying them. And I hope that you guys enjoy them and find them useful as well.
Yes, they are beautiful and wettable, and you definitely want to get your copy. So I will put a link in the show notes for you guys just to find them very easily and get your own. Gwenny, thank you so much for your time today. It's always good to chat with you. I feel like we could just go for hours and hours about the crazy things we saw and what we've learned from them, the hindsight wisdom we've acquired. But I think 50 minutes is going to be enough for today. So thank you so much for your time. Hope you have an awesome rest of your day. And we should do this again sometime soon. Bye, my friend.
Excellent. Thanks, Sarah. Always good to see you.
You too. Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.